My name is Kia Chalet, Professor of Neurosurgery at UC Davis. On behalf of my co-authors, Dr. Gregory Harluck and Dr. David Menon from University of Manitoba and University of Cambridge, it is my pleasure to provide a review of our chapter on the clinical pathophysiology of traumatic brain injury. In this review, we will be discussing the biomechanics of traumatic brain injury, the classification schemes used for traumatic brain injury, including the Glasgow Coma Scale score, and classification schemes based on injury patterns. We will discuss the effects of traumatic brain injury on cerebral circulation and cerebral metabolism. We will review the consequences of elevated intracranial pressure and its implications for management of traumatic brain injury. We will also discuss the significance of extracranial injuries in patients with traumatic brain injury. And then we will draw some conclusions from our chapter on the pathophysiology of TBI. As an introduction, it's important to note that traumatic brain injury has various stages. The immediate consequence of a mechanical injury to the brain results in tissue deformation, damage to neurons, glia, axons, blood vessels, and other support structures of the brain. After this initial mechanical injury, there are various second injuries that can occur in a more delayed fashion. We know that intra- and extracellular pathways are activated after trauma. We know that brain metabolism and cerebral blood flow physiology changes after trauma, and this can occur and persist for days or even weeks after an injury. Second injuries such as hypotension, hypoxia, seizures, fever, anemia, hyperglycemia, and others have been well described as the consequences of TBI. And during the secondary phase, cerebral edema and changes in metabolism and blood flow to the brain play a critical role in patient outcomes. A deeper understanding of these processes is critical if we are to optimize our management of patients with traumatic brain injury. During a traumatic event, the brain is exposed to a variety of forces. Some are linear, some are angular, and some are rotational, and these can cause varying degrees of mechanical damage to the brain tissue. In Figure 346-1, the mechanical damage to the brain is depicted here as being complex, and it is due to divisions between the brain regions, which result from dural reflections, skull-based bony ridges, and tethering of the brain at the sella turcica. In Figure 346-2, one can see that trauma not only results in focal injury to the brain, but there are also many areas deeper within the brain tissue that become affected. Focal injuries cause hematomas and contusions, but the acceleration and deceleration forces cause varying degrees of injury to white matter tracts, which are depicted in this figure. These can vary in severity, with the most extreme pattern of white injury matter being called diffuse axonal injury. Diffuse axonal injury, or DAI, can cause significant functional disconnection of brain regions, which results in profound neurological deficits, including the inability sometimes to regain consciousness. Figure 346-3 depicts the mechanism of angular acceleration that occurs during a typical brain injury. Diffuse axonal injury is felt to result from significant rotational acceleration, which injures both the subcortical and the deep white matter tracts. Rotational acceleration is a result of the head and upper neck moving around the center of angular acceleration, located in the mid to lower cervical spine. The magnitude of rotational acceleration is determined by the distance between the center of mass and the center of angular acceleration, both of which are depicted here. Traumatic brain injury can be classified in a variety of ways, including clinical severity, radiographic injury pattern, and CT classification score. This slide depicts the most commonly used clinical severity scoring scale, the Glasgow Coma Scale score. The Glasgow-Coma scale was first described in 1974 by Teasdale and Jennett and has become the most commonly used system to grade the severity of head injury by level of consciousness. As you can see in the table, the scale assigns scores for eye opening, motor response, and verbal response, and the scale ranges from a score of 3 to 15. The total GCS score, obtained after resuscitation of an injured patient, is used to classify TBI into mild, moderate, or severe, as depicted on the right. Although the score has been used for over 45 years now, and because it has become common in all trauma centers, it is something that we are all familiar with, but we should note that it does have important limitations. For example, eye score cannot be accurately obtained in patients that have severe orbital or facial injuries, and verbal score is often unavailable due to early intubation for airway protection and ventilatory support. The motor score has been shown to be the most reliable component, but it also can be unavailable or inaccurate due to sedation, paralytic therapy, or drug intoxication. An alternative way to classify traumatic brain injury is by injury pattern, depicted in Table 346.1. We can classify injuries as being focal or diffuse. Focal injuries tend to result in contusions and/or hematomas, and contusions can be further subclassified as being fracture, coup, contra-coup, herniation, intermediate, or gliding contusions. Hematomas are often subclassified anatomically as being located in the epidural, subdural, or intracerebral space. In addition to focal injuries, we know that many patients will experience some component of a diffuse injury as well. Diffuse injuries represent a wide spectrum, from the mildest form being a concussion, and more moderate and severe forms representing diffuse axonal injury. The radiographic imaging findings can be used to provide a score that classifies traumatic brain injury based on the initial CT scan. Depicted here in Table 346-3 is the Marshall score, which was introduced in 1991 from data that was derived from the National Institutes of Health Traumatic Coma Data Bank. The Marshall score classifies patients into 4 categories based on the extent of midline shift being less than or greater than 5 millimeters, the size of the lesion being less than or greater than 25 cubic centimeters, and the patency of the paramesencephalic cisterns. In 2005, a modified version of the Marshall score was introduced, the Rotterdam score depicted in the right table. This includes a point system scoring the CT scan on the status of the basal cisterns, the presence of midline shift, the presence of an epidural mass lesion, and the presence of intraventricular or subarachnoid hemorrhage. By adding a point to this score, this also results in a 1 through 6, and this modified score has been shown to more strongly correlate with clinical outcome. Focal injuries often occur at the impact site of the head or at the opposite side of the head, which is referred to as a contra-coup injury site. The impact site can experience a skull fracture, which increases the risk of an adjacent hematoma. The type of hematoma that a patient develops after a focal injury is defined by its anatomic location, either being above the dura, below the dura but above the brain, or within the brain tissue itself. The relationship between skull fracture and intracranial hematoma is depicted in Table 346-5. On the right side of the slide are depicted 3 examples of hematoma patterns. The epidural hematoma on the left is most commonly the result of a damage to the branch of the middle meningeal artery, which normally runs between the layers of the dura. The classic description of this hematoma is a patient that sustains a mild head injury or a concussion, then has a period of time without any neurological deficits, what is termed a lucid interval, then experiences neurological decline as the hematoma expands and causes mass effect. CT scan often demonstrates a biconvex lens-shaped clot depicted on this CT scan that typically does not cross suture lines in the bone. Treatment is usually surgical. The next scan depicts the typical appearance of a subdural hematoma. These are most commonly the result of damage to bridging veins that exit the subarachnoid space at the paramedian surface to enter the superior sagittal sinus. Acute subdural hematomas, as depicted here, appear as crescent-shaped clots that can cover the entire hemisphere of the brain, resulting in significant mass effect and brain shift. Treatment for these is usually surgical as well, but that decision is based on the thickness of the clot and the amount of midline shift. In some patient populations, such as the elderly, these clots can present as subacute or chronic hematomas, and their imaging characteristics can vary based on the age of the clot. This information is depicted in Table 346-6. Finally, on the right side is an intracerebral hematoma. These are clots that are located within the brain tissue itself, often due to direct mechanical injury. Since these clots are intraaxial, within the craniospinal axis, surgical evacuation is often reserved for those that are of significant size and/or cause significant mass effect with neurological decline. First described in 1956, diffuse axonal injury results from severe angular and rotational acceleration and deceleration, resulting in shear and tensile forces to the brain's axons. Many of the findings of diffuse axonal injury are microscopic and most evident on histology. They include disruption and swelling of axons, swollen and severed axons, and punctate hemorrhages. Diffuse axonal injury can sometimes be difficult to visualize on a routine CT scan, but certain MRI modalities, such as diffusion-weighted imaging or gradient echo sequences, can demonstrate areas of shear injury and small hemorrhages. Diffusion tensor imaging may also be a useful tool in visualizing white matter injury after diffuse axonal injury. Table 346-7 depicts a grading scale for diffuse axonal injury. DAI can be classified as grade 1, 2, or 3 based on the distribution of injuries. Grade 1 DAI primarily involves the subcortical white matter. Grade 2 DAI also includes the corpus callosum. And grade 3 DAI has all of the features of 1 and 2, but also demonstrates lesions in the peduncle at the midbrain. As described by an article published by Dr. Martin and colleagues in 1997, there appear to be three distinct phases of cerebral circulation after severe traumatic brain injury. Shown here in Table 346-8, the first phase is hypoperfusion, and this occurs on the day of the injury. This is defined by a period of time where cerebral blood flow is low, the velocity of flow in the middle cerebral arteries is normal, and the arteriovenous difference of oxygen is also normal. Phase 2 is termed hyperemia and occurs during the first 3 days after injury. This period is defined by increased cerebral blood flow, increased velocity of flow in the middle cerebral arteries, and a decrease in the arteriovenous difference of oxygen. The third phase is termed vasospasm. This occurs approximately 2 weeks after injury and is defined by a decrease in cerebral blood flow due to further increase in velocity of flow in the middle cerebral arteries. This can result in ischemia with a resultant increase in the arteriovenous difference of oxygen. The hemispheric index is also increased during vasospasm. Risk factors for the development of post-traumatic vasospasm are not completely understood, but some that have been described are the presence of intracerebral contusions or hemorrhage, fever or hyperemia on admission, and possibly the presence of subarachnoid hemorrhage, although not always necessary. Traumatic brain injury activates numerous intracellular and extracellular pathways that mediate secondary injuries. These result in a release of neurotransmitter, which causes excitotoxicity and oxygen-free radicals, a shift towards anaerobic metabolism due to ischemia, and increases in intracellular calcium that cause apoptosis and cell necrosis. For reference, Table 346-9 demonstrates the normal values and parameters of cerebral metabolism circulation in the healthy, uninjured adult brain. On the right side is a flowchart demonstrating how traumatic brain injury can result in inadequate cerebral blood flow with anaerobic metabolism and hyperglycolysis, resulting in cerebral acidosis, electrolyte disturbances, denaturing of proteins, delayed recovery of blood flow, and then eventual cell damage. Cerebral ischemia occurs when cerebral blood flow is inadequate to meet the metabolic demands of the brain. In a study by Bouma and colleagues in 1991, in the first 12 hours after injury, approximately 20 to 33% of patients with traumatic brain injury experience cerebral ischemia, and this is a predictor of worse outcome. When cerebral blood flow declines, AVDO2 increases, and at a particular threshold, neurons begin to experience synaptic dysfunction. This is followed by membrane failure, then sodium-potassium pump arrest, then cell swelling, then cell dysfunction, and finally cell death. Studies have shown that these changes begin to occur when cerebral blood flow is below 18 to 20 milliliters per 100 grams of brain tissue per minute, as shown in figure 346-4. Three hypothetical states have been described of brain dysfunction after head injury. This is shown in table 346-10. Ischemic brain, brain that is dysfunctional but can still recover, and irreversibly damaged brain. These three states. Cerebral ischemia occurs when cerebral blood flow is inadequate to meet the metabolic demands of the brain. In a study by Bouma and colleagues in 1991, 20 to 33% of patients experience cerebral ischemia in the first 12 hours after TBI. And this is a predictor of worse outcome. When cerebral blood flow declines, AVDO2 increases, and at a particular threshold, neurons begin to experience synaptic dysfunction. This is followed by membrane failure, sodium-potassium pump arrest, cell swelling, cell dysfunction, and eventual cell death. Studies have shown that these changes begin to occur when cerebral blood flow is below 18 to 20 milliliters per 100 grams per minute. This is shown in figure 346-4. Shown in table 346-10 are three hypothetical states of brain dysfunction after head injury. These are ischemic brain, brain that is dysfunctional but can still recover, and brain that is irreversibly damaged. These three states are all associated with low CBF and can be differentiated by the changes in AVDO2 that correlate with decreasing CMRO2 as cells eventually die. It is important to note that cerebral blood flow is age-dependent. As depicted here in figure 346-5, it is at its lowest value shortly after birth, approximately 40 milliliters per 100 grams per minute. Cerebral blood flow increases to a peak at 3 to 4 years of age, when it is approximately 108 milliliters per 100 grams per minute, a value that is double the normal adult value. Cerebral blood flow then decreases as children age, reaching near adult levels in the late teens. The average adult value is 54 milliliters per 100 grams per minute. Cerebrovascular reactivity refers to the different ways in which blood flow to the brain is responsive to physiological triggers. The first example of reactivity is metabolic autoregulation. Cerebral blood flow is normally coupled to CMRO2 such that supply meets demand and tissue does not become ischemic. Metabolic uncoupling can happen after traumatic brain injury, when cerebral blood flow exceeds CMRO2 and patients experience hyperemia. This can result in edema, elevated ICP, compromised CPP, and resultant ischemia. The second form of cerebrovascular reactivity is pressure autoregulation. CBF is normally kept constant when the mean pressure perfusing the brain, the cerebral perfusion pressure, increases or decreases within a certain range. This is accomplished by vasodilation when pressure is low and vasoconstriction when pressure is high. After traumatic brain injury, however, pressure autoregulation can be highly variable. It can be intact or it can even be absent. Some have suggested that each patient may actually have an optimal CPP range within which autoregulatory capacity is maximal. If autoregulation is not intact outside of this range, then an increase in CPP could result in hyperemia and increased ICP, and a decrease in CPP below this range could result in ischemia. Viscosity autoregulation is a third form of cerebrovascular reactivity. Since the ability for blood to flow through vessels is affected by the resistance it must overcome due to viscosity, there are mechanisms in place that allow for CBF to remain constant as blood viscosity changes. Vessels dilate when viscosity is increased to allow for constant blood flow, and vessels will constrict when viscosity is decreased to ensure that blood flow remains constant. Viscosity autoregulation is typically intact after TBI. The fourth type of cerebrovascular reactivity is a response to changes in pH and CO2. Termed carbon dioxide reactivity, cerebral arteries will dilate in acidemic situations where CO2 is elevated, and they will constrict in alkalemic environments where CO2 is low. This reactivity is also typically preserved after traumatic brain injury. Now, the effects of various therapeutic interventions that we provide to patients with traumatic brain injury depends heavily on the autoregulatory status of the patient. Table 346-11 summarizes the responses we see in cerebral blood flow, cerebral blood volume, which affects ICP, and the AVDO2, which can predict the development of ischemia and cellular damage. For example, the effects of reducing CPP are very different when autoregulation is intact, such as condition number 2, as compared to when it is defective. In a patient that lacks normal pressure autoregulation, a decrease in CPP can result in increased AVDO2 and cerebral ischemia. On the other hand, a patient with intact autoregulation will experience no change in AVDO2 when CPP is decreased, since the CBF remains constant. However, the vasodilation that normally occurs with decreased CPP can actually result in increased CBV and an ICP spike in this setting, which can then have secondary deleterious effects. Understanding how different autoregulatory states influence the effects of therapeutic interventions is critical to effective critical care management of severe TBI. Tables 346-7 and 346-8 show the effects of volume on pressure and how this is relevant for intracranial pressure or ICP. ICP becomes elevated when intracranial volume increases beyond the state of compensation. The Monroe-Kelly doctrine states that the total volume of intracranial contents, brain, blood, and CSF, must remain constant if pressure remains constant. In other words, an increase in one compartment, such as brain edema, must be compensated for by decrease in one of the other compartments, such as blood or CSF, if ICP is to remain in the normal range. There is an ability to accommodate an increase in volume through passive compensation, such as reduction of CSF volume or reduction in venous blood volume. But at some point, patients enter an uncompensated state where further increases in volume are no longer tolerated. At this point, we see a logarithmic increase in ICP with any further increase in volume. Using a semilog scale, a linear relationship can be described and the pressure-volume index can be calculated. This is depicted in figure 346-8. Understanding if a patient is in a compensated or uncompensated state is very important when making patient care decisions in the ICU. As ICP becomes elevated, there can be pressure gradients between intracranial compartments that will drive shifting of brain tissue from one compartment to another. This movement of brain tissue is termed herniation, and this can result in mechanical injury to the brain, as well as cranial nerves and critical vessels. 5 major patterns of cerebral herniation are described in Table 346-12. Each have characteristic structures that can become involved and characteristic clinical symptoms that can be observed at the bedside. Although this chapter has primarily focused on the brain and its supporting structures, it is important to remember that traumatic brain injury often occurs in the context of extracranial injuries that can significantly impact neurological recovery after TBI. For example, patients with significant limb, thoracic, or abdominal injuries can experience blood loss causing hypotension. Similarly, patients with a spinal cord injury can develop shock due to loss of sympathetic tone. Systemic hypotension is extremely detrimental to the injured brain as it compromises cerebral perfusion pressure. If pressure autoregulation is intact, the effect can even be worse since a compensatory vasodilation results in increased CBV and ICP spikes, further complicating TBI. Therefore, preventing systemic hypotension is critical in management of TBI. Severe hypoventilation, airway obstruction, aspiration, pneumothorax, or hemothorax can often occur in the setting of TBI and cause systemic hypoxia. In the first 24 to 48 hours after injury, hypoxia can also result from atelectasis, fat emboli, pneumonia, and acute lung disease. Hypoxia results in cerebral ischemia, cerebral edema, and worse neurological outcome, and should also be aggressively prevented in TBI. For each degree Celsius elevation in body temperature, cerebral metabolism has been shown to increase by 10 to 13%. If metabolic coupling is not intact, this can cause ischemia. If metabolic coupling is intact, blood flow will increase, and this can result in elevated ICP with a resultant decrease in CPP. Therefore, maintaining a normal temperature after trauma is very critical. Hemoglobin-bound oxygen is necessary to meet the cerebral metabolic demand of the brain, and anemia can have profound effects on neurological recovery after TBI. At the present time, it is not known what hemoglobin levels should be targeted after TBI, and further studies are needed to understand the positive and negative effects of blood transfusions after head injury. Increased glucose levels can lead to increased anaerobic metabolism of glucose via glycolysis, which can cause secondary cellular injury from lactic acidosis. For this reason, dextrose-containing solutions should generally be avoided after trauma, and glucose levels should be kept within a normal range. Finally, low magnesium after TBI has been correlated with worse neurological outcome. It is important to note that magnesium replacement therapy has not been shown to be beneficial, and further research is needed to understand how hypomagnesemia can impact outcome after head injury. In conclusion, our chapter on the pathophysiology of traumatic brain injury reviews the mechanical damage as well as the intra- and extracellular pathways that are activated after an injury to the brain. We review the ways traumatic brain injury can be classified both clinically and by the anatomic pattern of injury. We highlight the importance of a strong understanding of cerebral circulation and metabolism after TBI, as this can direct therapeutic interventions. The fundamentals of TBI management are managing ICP, managing CPP, and preventing the additional insults that can occur due to both intra- and extracranial processes. Thank you.